Hiya and welcome to the channel. Today we'll be thinking about the differences in training and in the role between a PWP and a CWP. And PWP stands for a Psychological Wellbeing Practitioner, and CWP stands for a Children's Wellbeing Practitioner. And today with me, I got Chloe, who is doing her CWP training right now, and Jordan as well, and he's just finished his PWP training. So yeah, today's kind of an overview, but I think we're gonna dive into some detail about some of the things. And then I'm hoping in the future as well to do individual videos with both Chloe and Jordan to kind of really, get into the details. But let's just get into it. So both are wellbeing practitioner jobs. For both of them, you need to do a postgrad certificate. And the PWP role is actually a little bit more established. I think it sort of came to be in about 2008. And then a CWP role is much newer, so it was about 2017. So first question really, what is a PWP and what is a CWP? Over to you guys.
I'll go first. Yeah, so I guess the PWP role, again, I might answer a bit for Chloe as well, but we specifically work under the kind of low intensity cognitive behavioral therapy title within like the kind of the different talking therapies. So effectively what I would do is kind of assess and then deliver interventions at a lower intensity level. Now, with the PWPs, we're meant to work with individuals who are being impacted by mild to moderate symptoms of low mood or anxiety. And we do treat a number of the anxiety disorders as well. So that's including OCD, panic, social phobia, health anxiety, and I think that's all of it. And obviously generalized anxiety as well as low mood. So I guess that's a quick summary of mine.
Mm-hmm. And as for me, as like a CWP, so it's quite similar to Jordan. So I kind of assess and do interventions with young people or parents actually, because I kind of sit within a CAM service. And basically that just entails kind of delivering these interventions with them. And it's kind of based on, similarly to Jordan's, like anxiety or worries, low mood and depression. And also we do kind of look at behavioral difficulties and sort of some form of emotional regulation as well. So we kind of just provide strategies, use lots of tools and techniques to essentially teach young people and parents to kind of manage and cope with their difficulties going on.
Mm-hmm. And then in terms of where PWPs and CWPs work, would you guys ever work together? Are they completely different services? So both in terms of the kind of services side, but also the population you deal with. So for Jordan, I guess one of my questions would be, would you work with older adults as well? Because I know sometimes that's a separate service. And then Chloe, would you work with young adults as well? Or does it kind of end at 18 and then they'd go into a different service?
So I guess with the PWPs, we're set up within a service that is called IAPT, which stands for Improving Access to Psychological Therapies. So in my time working within IAPT, we have worked from, I think the youngest I've had is around 16 years old and 8 months, kind of when they're getting around to that kind of discharge away from CAMS. And yeah, we'll happily work up to, older adults that has no limit. I guess you could kind of look at an IAP service as like a GP in some respect. Do you know what I mean? Like you kind of come in and then your broader issues are kind of reviewed or assessed with myself. And then let's say from the older adults perspective, if there was maybe any impact from any kind of neurological, element, if it was maybe early onset of dementia and things like that, then it might be that their needs are then reviewed and sent to older adults care or something like that, or maybe a community mental health team. So I guess you could look at the PWP role and IAPT, in the first instance, assessing any kind of difficulty that someone would have from a mental health perspective, similarly to what maybe you would do with a GP when you've maybe got, I don't know, an ongoing pain somewhere, or chesty cough and things like that that's been there for a while. You'd go to your GP to check that out. So yeah, we work with a range from kind of, as I say, when the patient might have been discharged or at the point of discharge of a CAM service, all the way up to, I think the oldest patient I ever treated was around about 88. So yeah.
Okay. And for me, I guess, so So like I said, I sort of sit within a CAN service, but it's not unusual for CWPs to also be based in third sector sort of organizations, so things like charities. And I've known that to be the case with some of my sort of course mates as well, because it is quite a new role. And in terms of like population, so like I sort of mentioned before, it's young people aged from about 11 to 18 that I do interventions with. So that's kind of working directly with them. And then when the children are a bit younger, maybe around 5 to 11, I would often work with the parents, just because of kind of that developmental age. And we kind of, parents tend to be the experts, and they're kind of best placed to carry that intervention out with the children, essentially. And what we do tend to see as well is that we don't really, because it's quite low intensity work as well, as Jordan sort of stated, and we also work kind of according to CBT principles, and that's what our manuals are based on. The young people and children, they don't tend to have like diagnoses yet. If they did, it's not necessarily a massive issue. It just might mean that they need a referral onwards, just depending on kind of their circumstances and situation, and kind of the level of difficulties that they're actually experiencing as well. So that's it really.
I think similarly to what Chloe said as well with our IAP services, and maybe were quite helpful for people, is if you work as a low intensity therapist or even a high intensity kind of CBT therapist or counsellor, we don't ever diagnose with a mood disorder. We would never say, you have anxiety or you have depression. I guess the best way to define what we do or what we experience and what we're trying to work alongside is I guess the dialogue we have with the patient is that they're presenting with symptoms of the said disorders, and those interventions, those low intensity interventions, are there based to help reduce the impact of the symptoms, if that makes sense. So you would never, in terms of your clinical responsibility as a PWP, and I'm assuming the similar for a CWP, is that you would not give that formal diagnosis. That's always still given to responsibility of a psychiatrist or a doctor. That remains as a medical standpoint.
Mm-hmm. And would you guys make your own clinical decisions, or are you working sort of under supervision of someone else as well?
I guess what do you mean by like clinical decisions as well? Because essentially I was just sort of thinking like the way that my service works is, one, services do operate differently. So I can only really speak from my own experience. But we tend to have sort of a senior mental health practitioner, such as a psychologist, or, like sort of a band 6 and above, that do sort of a screening initially, just to see if that person might be appropriate. And then we kind of do the assessment, and essentially that would then be down to us to kind of say yes or no if they are actually appropriate for the intervention. So we do essentially have responsibility. And even though we are a low intensity service, it's not uncommon, I would say, to carry some form of risk as well sometimes. But obviously, as a trainee especially, like we're really like sort of heavily supported and supervised. I've kind of got like my own supervisor, and she's actually a clinical psychologist herself. And then I also have my manager as well, sort of for backup and support. So we discuss like all cases in sort of team meetings as well, and kind of raise any issues there. So essentially, I think we're quite well supported, even though we're kind of making our own clinical decisions, and especially like during interventions as well. So I'd often work very person-centered, and I'm sure it's probably the same for Jordan, being a PWP as well, where it can sort of bring things to like children or young people or parents, and then we kind of look at it together and kind of try and make that joint decision based on what we feel would be best for that person at the time.
Yeah, kind of. Similarly to Chloe, I think with what Chloe was describing there, in terms of you'd have like a maybe like a band 6 or 7 doing the initial kind of screening first. My experience of the PWP service is that would happen if the individual had either come to our service off of maybe contacting crisis prior to that, because sometimes with what our pathway was for my old service was that if they, for whatever reason, maybe they called crisis team, the crisis team were able to assert that they'd be safe, they would then be brought over to us. And then, like Chloe said, one of the clinical supervisors would have a look through them to see if the person was appropriate to be assessed by us, not to see if they're appropriate for the service. Because as the PWP, it sounds like similar to Chloe as the CWP, is that on your assessment, you would then decide whether that patient is appropriate. So, and then at the same time, if someone, you can always come to IAP services as well. You can call them, so you could just punch into Google in your local area and then IAPT, and then that will come up if you just wanted to chat to someone as well. Then again, you would probably, the first thing that would happen is you'd get a booking for your assessment, and then a PWP would assess your current difficulties. And then based on that, at the end of that assessment, ourselves as the PWP would say, right, yes, this person is appropriate for step 2, which is like the low intensity level, which is what I work at. And again, they do the interventions that I would work on. Or if their difficulties were maybe a bit more severe, so if someone was maybe presenting with PTSD, or they've had like recurrent episodes of depression or quite severe anxiety, then you would kind of formulate a rationale to say that they need to be stepped up into higher intensity treatment. And then similarly with Chloe as well, during your treatments and when you've got your patient caseload, I guess, they are your patient, and you decide collaboratively what's best for them. And you make a lot of the clinical decisions. But again, you'll have like, an hour every week of case supervision with your supervisor. And we also have a clinical skills supervision, which is done between like, your other colleagues as well, to maybe chat about a case discussion too. So there is a lot of responsibility, I think, by sounds for both of us, that, we do make quite a lot of decisions, but at the same time, you're well supported as well for those maybe more complex presentations too.
Yeah, definitely. I also want to pay mention as well to university as well, because obviously we're also, we're training, and I know like my university, they've also provided like lots of support. So like tutors have been on hand as well, kind of if you want to share anything. And, we do actually share lots of videos sort of in our clinical skills days of like our actual videos, when we're seeing young people or their parents, and we kind of can also bring like sort of maybe a case that we're struggling with that we want other ideas on. And like the tutors, they're all kind of they've all got really like well-established backgrounds, either like social workers or in mental health, like psychology, so that's also like a really good resource for us as well, like of support. But yeah, I don't know if it's the same for Jordan too.
No, I completely forgot to mention them, to be fair, which is quite bad. So yeah, I think it's got to be a requirement, right, that like all of the tutors themselves, they've got to have at least a minimum of like 2 years clinical experience before they can do educator roles as well. So your whole like training network is based with clinicians, whatever happens, whether it's from obviously the service side of stuff or during your the education and academic side as well.
Cool. So I'll go back to the training just in a little bit, but so you both said that it's low intensity therapy. Is it just the CBT model that it's based on, and then sort of seeing how it applies to these different conditions, or would you use other models as well?
Well, I think the PWP and I'm sure the CWP role is strictly CBT. Mm-hmm. So you're trained through a CBT, obviously, kind of remit. In terms of I'm not sure what the pathway is for counselling. I don't think there is like a low intensity like equivalent to if you wanted to be a counsellor. So that pathway is something that I have no idea about. But yeah, it's strictly CBT.
Yeah, I mean, I'd agree with Jordan. It's sort of the same. Like from the outset, you're kind of taught it's based on like the cognitive behavioural therapy principles. And obviously it's like very sort of evidence-based as well, which is great, and it's been shown to be quite like effective essentially. I don't think I've sort of had any sort of like experience outside of that, if that makes sense. And I'm sure there'll probably be a question later, but there is opportunity sort of further down the line once you've maybe trained for a couple of years as like a CWP. I don't know if it's the same for PWP too, but to then go on to like more either like higher intensity sort of therapy courses. So there's always that option too.
Mm-hmm. And then a slightly more personal question, but why did you choose to be a PWP rather than a CWP, and then vice versa? Is it just the kind of kids working with children element, or was there something else?
For me, I mean, I was applying to both PWP and CWP roles. I never actually thought I'd get the CWP role, to be honest, just because like a lot of my experience, it hasn't been directly with children. It's more been with like sort of adults and kind of like verging on like, adolescents, teens to like adulthood. But one of the main reasons why I sort of did it was I was kind of toing and froing to sort of do a master's. And then I guess just with a master's, I was sort of thinking I don't really have like the resources to do it, to sort of like stay in London and kind of study and then, like sort of survive as well on top of that. And I remember sort of like learning about the PWP, CWP roles. And obviously they're higher education England funded as well. So I kind of saw it as a really good opportunity to, train and learn. I'm also sort of getting, a good wage as well, sort of with that. So it just seemed like sort of the ideal option for me. And obviously I sort of do have a psychology background, and I have always sort of enjoyed working in mental health. And it kind of, I guess, falls into maybe some future plans in applying for the clinical psychology doctorate, potentially, depending on how I'm feeling.
We've all got dreams. We've all got dreams to get onto that, but yeah.
I know, I'm sure we will come on to that later. But yeah, so that's kind of like essentially like the main reasons for me why I picked sort of that role.
And Jordan, for yourself?
For myself, for myself, I mean, I wanted to stay in adults because I think the work, obviously, us three have worked together previously at our old trust as well, and I'm just not. I know that I wouldn't probably have the patience for children as much as I would adult therapy. I don't know why. I just feel like
Honestly,
I wouldn't.
right.
But then saying that, yeah, well, saying that, some of the adult patients I've had, it's like, oh god. So it's a similar thing. Like there's no difference. But I think for me as well, what a lot of my clinical reasoning for why I didn't bother the children's one is that I don't feel confident enough knowing, right, what is the difference between this child just going through, that natural stage of like teenage angst that we all go through, and then where is it like a clinical problem? And I feel like, especially with everything that they see now, like the content they go through and look at, like, when I go through my sister's TikTok timeline, so it's wild, some of the stuff that comes up on that, particularly when these people are screaming about the symptoms they need to have for all their difficult mental health issues. And it's like, I don't know how I'd help treat that. And it would just be like, do you know what I mean? Like, there's a lot of external factors now that are quite challenging for that. And again, like, as I say, tip my hats off to Chloe for doing it, because it's like, I just, a lot of that, there's a lot going on for kids that age where it's too much for maybe that I would be able to support. And I just feel like with adults, it's not easy. I mean, it's not that at all, but I just feel like there's just that common ground that I feel like it's a lot easier to problem solve with them. And you could spend a bit more time poking and prodding at things, whereas when I've had my younger patients around 16, 17, it's a lot of the time it's a case of, I don't know, and then they get really wound up. And it's therapy isn't like it's not a simple thing. It's not easy. And I think trying to get that understanding for them first is usually the biggest battle before your treatment is even beneficial. I think that's probably why I stuck with adults, or the reasons why I stuck with adults over that of children.
So I'll ask you about sort of applications and training in just a sec, but in my head, I think the difference between PWP and CWP is still that they're kind of similar, but one is with adults and the other with children. Do you think that's fair, or do you think there's any other sort of key differences that we missed out on in the role itself?
I mean, I guess we've like pretty much touched on them. I know, I sort of said with our interventions as well as like a CWP, we do behavioural difficulties. So that's like sort of when parents are finding certain behaviours may be challenging sometimes. I feel like that's just like kind of an added extra though, but also it does fit in with the population that we see. So I'd say that's the only difference. I guess as well, you could say the training is slightly different, even though it's sort of based on the same CBT principles. And, we do have manuals that like really help guide us sort of when we're delivering interventions. I remember I think I sent Jordan one of like the manuals ones because he just wanted to like have a look over it, and he was like, oh my god, this is so long. So I don't know how like long Jordan's are, but we are very like supported like throughout uni, and like I said, sort of in my clinical practice where we sort of have a plan like session by session. And obviously kind of you when you're like sort of seeing the young people or parents, it's kind of up to you kind of how you deliver that essentially. So I do think there are definitely similarities there. I guess it's just those like minor differences between sort of being young people and adults, definitely. So yeah.
Jordan,
Yeah,
anything more to
I'd
add?
completely agree. No, I just completely agree. I think from the talking therapy side of things, you will train alongside the CBT model. Like that is similar. But I guess Chloe, how long are your sessions, and how long do you see an individual patient for? Have you got like a time limit or?
So our sessions are typically up to an hour. That's how long we sort of have. Sometimes sessions, though, it can depend sort of at what stage of the intervention you are, because we do like the odd review kind of session, which might only be, about 20 minutes or so. Or if I guess, it's quite straightforward, you might be having like 30-minute sessions. So it can entirely sort of like vary on the individual itself. But generally speaking, we'd see them for like about an hour maybe.
And then do you have like a set number of times you'll see them or not?
Ours is once a week. So we tend to offer around like 6 to 8 sessions, and that's over
Okay,
the
yeah.
6 to 8 weeks.
Yeah. So again, that's probably the same. Well, a little bit difference is that the PWP sessions are half an hour. And from my service, we did sessions every fortnight, and I think it's the same as well with any other PWP service would be the same. But we do have between a maximum of like 4 to 6 sessions as well. But again, give or take a bit more time if maybe you maybe got an older adult that likes to talk a bit, or any hearing difficulties, or if you need to make room for any kind of maybe long-term physical health conditions as well. It's kind of give or take each individual, but yeah. So it sounds like that we're quite similar with that maybe.
I think we also spoke about, didn't we, as well, like, because we've both done like workshops in our respective sort of services. So we don't necessarily have like a specific group, we deliver on like a weekly or monthly basis, but we've been doing like ad hoc workshops at the minute. So I've done some stuff around like for young people sort of transitioning to secondary school. Obviously with a lot of young children kind of going into secondary school this year, and especially actually considering like all the stuff that's gone off with COVID. So that's actually played like kind of a big part in some of our workshops and our sessions as well, actually. But it's kind of good that we can kind of have those opportunities to do that anyway. But we also do stuff like sleep workshops, or kind of just like stress workshops as well. So yeah, I don't know if yours is similar.
Yeah, no, we've got all these that same, so kind of stress less workshops, some low mood workshops as well. They'd usually be given to, or that people would go on to those if maybe the scores that they do. So we've got something called like, or with PWP work anyway, we work with something that's called a minimum data set. So it will be the PHQ-9 questionnaire, which looks at symptoms of low mood, the GAD-7 questionnaire, which is looking at symptoms of anxiety. We look at the WASA scale as well, which just looks at how the difficulties impact an individual doing kind of tasks in their day-to-day life. And there is also there's another scale as well, and I forget the name of it now, but just looks at kind of specific specific phobia scale, but there's a name for it and I've forgotten. But we do that as well. And I guess if maybe at an assessment an individual came to us and they were scoring quite low, they were having like understandable difficulties, but it's not maybe something that you would want to allocate specific one-to-one therapy time for, even at low intensity, because that seems too high of an intensive level for their difficulties. Then we might give them the support on the workshops instead, which is run by therapists, and they have check-in calls. But just sometimes even that can be more than enough for an individual as well.
Cool, thanks. I just noticed we have like 8 minutes remaining because I didn't upgrade to Pro. But yeah, we'll whiz through the next questions. And so we touched a little bit upon the training, but if we do individual videos, we can talk about that in more detail.
Sure.
But can you tell me, what was the application process like? So they're both postgrad certificates, but is it sort of similar, or?
I think we actually had different experiences, Jordan, because I know, do you mean like sort of that application process to like uni and sort of the job itself as well? Like that?
Yeah. And is it the same for both of you guys?
So mine sort of happened during the pandemic as well. So I think under normal circumstances, it would have been slightly different. Mine was kind of entirely virtual. So I did sort of a virtual interview with my trust. So it was actually kind of like a job application, and I did that through sort of NHS Jobs, I think it was. So I kind of submitted my application through there, and I, got an interview, kind of did a virtual interview, and I was just kind of asked sort of the usuals, like about 6 questions. It kind of focused around general themes, some sort of around risk. Service development was also a big one, and then just kind of a few general typical questions that you might get asked, such as, what qualities do you bring to the role? I'm trying to think as well. I think with uni, it was quite weird because it's sort of done in conjunction with each other. You just essentially have to meet the university requirements, was my understanding. So as long as you met their requirements, which I think was like, you might have to have like a relevant undergrad degree sort of in a specific area at a certain level as well. And I think that was pretty much it for the uni one, to be honest. And then I think the kind of trust was in contact with the university, and then they kind of said, she's great, we want to offer her the job, and then they kind of do it together. So it kind of was a bit separate. I don't think it was the most cohesive process, mine, but I also don't know if that's just because it's still quite a new role, so they were still kind of figuring the things out, but it was quite smooth. It was okay.
Yeah, no, I was the same, I think. So I applied for the trainee PWP role on NHS Jobs. And then luckily I had my interview prior to the pandemic kicking off. So it was like a big group day, but there was obviously the trust representatives, and then there was some of the academic team from uni as well. And then they kind of interviewed us both at the same time, or they both interviewed me at the same time. So like a panel of 3 people, and then myself. Once you get through, if you're successful getting through to the group stage, and then that once they were happy with it, just a thumbs up, and then it asks you to do another application, or not application form, but a cover letter for uni. I just copied and pasted the same one I used for trust, and it was all good because they gave me the job. So I was like, I'm probably gonna be lazy here.
You also had to do a role play, didn't you? I didn't in mine, but I think that was just because obviously it was pandemic time, but yours was pre. So
so I had to do. Oh, mate, my actually thinking about it, my day was mad. So there must have been about 70 people. So this was so no one had been offered the job. It was just come in for an interview day. Got there and there were 70 people. So what they did was they made loads of activities. They had people school when you did your exams and you're all on one table in a school hall. So for some of the role play stuff, there was 2 of us on a chair in this massive hall, but then there was loads of other people doing the same. And then you've had some the clinical team walk in and out, listen to the conversations we're having, write stuff down. It was mad. It was honestly I've never felt more competitive in an interview in my life than I did that day. I was like,
I'm happy I didn't have to do this.
Honestly, it was wild, but it was good though. And then I had to do a 2-minute presentation on so I did mine on stress and the stress response. I had to do that, and then we did a mock clinical skills supervision. And within that supervision, it was based on one of the therapists had a really nasty client, and they were seeking support as well. So we had to go and do that. And then we did the classic, your plane's crashed. What things do you want to grab from the plane to survive till you get help? It was wild, Julia. Honestly, I was like, "This is
boring compared to yours."
Dude, well, do you remember when you and me interviewed at our old trust? We had to just make a statue with an egg, and that was it. And then we just and then me sat there with 70 odd people. It was actually quite interesting. That was the first time that I would say that I've ever had that kind of interview process. So, but it was all good. And similarly, they'll go through stuff what would you do in this situation if X, Y, and Z patient responded with this? And it's just the standard, you know, make sure they're safe, go and get a senior member of team, and, you know, break confidentiality if it's appropriate, basically, and all that stuff. So
it sounds, it sounds quite similar in the application process itself, but I guess the interviews might vary depending on the uni or because of the pandemic as well. But I guess for the CWP role, presumably you need some experience with kids or young people as well, in addition to that, or? I
can't, I think it would be, do you know, like obviously normally with NHS roles, they have like essential and desirable. I don't actually know if it was like essential or desirable. I had also kind of, like I said, in my previous roles as well, I had come across like sort of adolescents as well, even though I worked in predominantly adult sort of roles. So I kind of drew on that experience and from what I learned like there essentially. So it's not impossible to get on, but you do tend to find lots of kind of teachers, things like that. I've known like social workers as well to kind of hop onto the CWP program.
Cool, because we are running out of time. Maybe just sort of last question. So is career progression in both the jobs the same? So you're working at a step 2 CBT model, and then can you be a senior PW? I know you can be a senior PWP, but is it the same with a senior CWP, and then that's the step 3, or is there anything beyond the senior PWP? Does the world continue, or is that it?
I mean, I think things are changing. I feel like there's been lots of stuff going on with, like, I guess the psychology route just generally, and kind of these sorts of programs. I know with my sort of role, they are going to become accredited. I think it's this year by the British Psychological Society. I don't know if the PWPs already become accredited actually, or if it's kind of going through the same process, but they're kind of, I think, working in conjunction with each other there. So that's obviously a step in the right direction. Like I said, you can, after you've sort of been in a qualified CWP role for like 2 years, there's the opportunity to then go on to do high intensity training. I think with it still being quite a new role though, there's some uncertainty on what kind of direction you can go in, but I would also argue that being a CWP, like doing that kind of role, is it's a job in career in its own right as well. So that's always like an option there. And obviously you can always go into like things like doctorates. I've known that to sort of happen as well in the past. So yeah, I think there is, I think it's developing and it's growing, but at the minute it is somewhat limited.
It's funny you say at the minute, because we've got less than a minute left and it doesn't tell us how much. It could be 5 seconds, it could be 30 seconds. Anyway, thank you so much, Chloe and Jordan. We'll definitely catch up and do a more in-depth video at some point. Definitely to hear more about Jordan's mad day as well. Standard goodbye Zoom wave. Thank you so much.
All right, speak later.